So this lecture is on the disorders of Micturition for the neurology resident rounds. To start with, we'll just go over some of the anatomy. So the urinary bladder is divided into the neck or the tricone, where the opening of the ureter is lie, and the body, and it serves as a low-pressure reservoir. The urinary bladder, also called the detrusor muscle, consists of 3 interwoven layers of smooth muscle. Adrenergic and muscarinic cholinergic receptors lie within the detrusor smooth muscle. Sympathetic fibers are found in the pelvic plexus, the pelvic ganglion, and the urinary bladder. They serve to enhance the storage phase of micturition. The preganglionic sympathetic neurons in the bladder are located in the lumbar spinal cord from L2 to L5 in the cat and L1 to L4 in the dog. The preganglionic fibers course as the lumbar splanchnic nerves to synapse with nicotinic cholinergic receptors in the collomesenteric ganglion, and postganglionic fibers continue as the hypogastric nerve to the urinary bladder, urethra, and pelvic ganglion. Both alpha and beta adrenergic synapses have been found on neurons in the pelvic ganglion in the bladder wall and on detrusor muscles, especially in the area of the tricone. Stimulation of beta adrenergic receptors causes detrusor muscle relaxation and allows bladder filling at constant pressure. Pharmacologic studies have demonstrated that alpha adrenergic receptors are located primarily in the tricone area, the bladder neck, and the proximal urethra, causing contraction of smooth muscle. The presence of adrenergic synapses on cholinergic ganglion cells suggests that sympathetic pathways can also modulate the activity of the parasympathetic pathway, but this effect has not been demonstrated in naturally occurring sympathetic firing. The preganglionic neurons for the parasympathetic innervation originate from S1 to S3 spinal cord segments. The preganglionic fibers from S1 to S3 leave the spinal cord as the pelvic nerve to synapse in the pelvic ganglion located within the bladder wall and innervate the detrusor muscle via cholinergic synapses for bladder contraction. The pudendal nerve arises from the ventral branches of S1, S2 sacral nerves to supply the striated external urethral sphincter muscle. Sensory fibers originating from the bladder run in both the pelvic and the hypogastric nerves. Sensory fibers from the hypogastric nerve reach the spinal cord at the lumbar segments to then the cerebral cortex. Stretch receptors in the bladder wall give rise to fibers that run through the pelvic nerve into the sacral spinal cord and ascend to the pontine reticular formation to initiate the detrusor reflex. The hypogastric fibers respond to overdistension of the bladder. Activation of these fibers can be perceived as pain. A lesion of the caudal-lumbar or sacrospinal cord could abolish micturition, although the animal would still perceive overdistension of the bladder as a painful sensation mediated through the hypogastric nerve. The bladder distension stimulates both small myelinated type A3 or A delta fibers and small unmyelinated type C fibers, which will be the focus for this slide. So the type C unmyelinated fibers are the pelvic nerves that reach the spinal cord and synapse on the interneurons of the gray intermediate matter. Some of these interneurons stimulate somatic cholinergic neurons of the sacral segments or preganglionic sympathetic neurons located in a number of spinal cord segments, which we will discuss later. A number of these neurons in the sacral segments, known as Gert's nucleus, receive neurons from the bladder through the pelvic nerves, project through the spinal reticular tract. From the spinal reticular tract, this will project to the pontine reticular formation. The bladder distension also stimulates small myelinated type A3 fibers in the hypogastric nerve that reach the spinal cord and either synapse on neurons in the gray intermediate matter to form the spinothalamic tract, or forgo synapse and then enter the gracilis fascicle. The neurons within the spinothalamic tract are thought to be for superficial pain, while the neurons in the gracilis fascicle are thought to be for bladder stretch or tone. The bladder distension stimulates small myelinated type A3 fibers of the pelvic nerve that reach the spinal cord and synapse on the interneurons of the gray matter. Some of these interneurons stimulate small cholinergic neurons of it's spelled ONUF, so the ONUF nucleus of the sacral segments. The axons of the cells of this nucleus form part of the pudendal nerve that increase tone of the striated urethral muscle to retain urine. Other interneurons stimulate the preganglionic sympathetic neurons located at the lumbar spinal cord segments. These preganglionic sympathetic neurons reach the caudal mesenteric ganglion to synapse on postganglionic neurons that form the hypogastric nerve. They allow the distension of the bladder and increase the tone of the neck of the bladder. A group of neurons in the sacral segments, known as Gert's nucleus, G-E-R-T''S, receive neurons from the bladder through the pelvic nerve, project to the periaqueductal gray matter of the brainstem. During storage, descending pathways from the medulla oblongata to the onus nucleus help maintain continence by contracting the pelvic floor in stimulations that increase intra-abdominal pressure. It's the increase in intra-abdominal pressure. So when the bladder is stretched, it sends signals from the pelvic nerve to intermediate gray matter, or Gert's nucleus, through the spinal reticular tract and to the periaqueductal gray matter, then to the pontine Micturition center. From here, the detrusor reflex can be inhibited by cortical input. Recall that the hypogastric nerve also has sensory input and is mainly responsible for the cortical perception of the bladder being full, especially in the dog. Its fibers run through the spinothalamic tract and the gracili fascicle, eventually making its way to the hypothalamus, cingulate gyrus, and frontal cortex. In the cat, the pelvic nerve also has some cortical input from the pelvic nerve. When it is deemed appropriate for urination, cortical input will inhibit the Micturition reflex. If it is deemed appropriate, the pontine Micturition center will then be released and urination will occur. The cerebellum can also inhibit the detrusor reflex. Stimulation of the fastigial nucleus abolishes detrusor reflex contraction. Lesions of the cerebellum, such as cerebral hypoplasia, may produce increased frequency of voiding with a reduced bladder capacity. Cortical input can also increase pudendal nerve activity by way of cortical spinal tracts. Got a little behind on my slides here. So there's the inhibition. Hold on. Okay, so the periaqueductal gray matter projects to the pontine Micturition center to start the Micturition reflex. Descending glutamatergic projections from the Micturition center activate preganglionic parasympathetic neurons in the gray intermediate matter. These neurons project via the pelvic nerve to postganglionic neurons in the pelvic plexus. The descending pathway also inhibits preganglionic sympathetic neurons in the spinal lumbar segments to stop distension of the bladder. The acetylcholine from the parasympathetic fibers induces contraction of the bladder and inhibits release of norepinephrine from sympathetic terminals. Also, descending inhibitory GABAergic and glycine pathways reach the onus nucleus to facilitate the relaxation of striated urethral muscle, allowing voiding. Descending pathways from part of the pontine reticulospinal tract and the ventral funiculus, along with other pathways involved in the cortical spinal tract and the lateral funiculus, have also been described. So now that we've gone through the pathways for Micturition, we can now discuss some disorders of Micturition. So here they are listed out, and we'll just go through them one by one, talking about where the lesion location would be in order to cause one of these disorders, and then what the treatment recommendation would be. So if you have detrusor areflexia with sphincter hypertomus, this is your classic upper motor neuron bladder. A lesion anywhere from L7 to the brainstem can cause this. Recall that the pelvic nerve is involved in the detrusor reflex, where it sends a signal to the pons, the lumbar spinal cord segments, and also the pudendal nerve. Without input from the pelvic nerve, the onus nucleus will then be stimulated, either from the local reflex arc or from its loss of upper motor neuron inhibition. And the hypogastric nerve, although it can send information to the cortex, the pontine Micturition center is not involved. Therefore, there is no inhibitory signal from the sympathetic system, meaning it is still being stimulated. So with upper motor neuron bladders, because of the disruption of the reflex arc, typically we are giving a alpha adrenergic blocker. So phenoxybenzamine, which is a non-specific alpha adrenergic blocker, or prazosin, which is an alpha-1 adrenergic blocker. This is to decrease tone to the internal urethral sphincter. Although sometimes we can give something such as ethanocal, it's rarely given because we can actually increase tone to the internal urethral sphincter by stimulating the hypogastric nerve as well. We can also give Valium for these patients too. Valium will help decrease tone on the bladder wall, on the abdominal wall, and then it'll also increase tone to the external urethral sphincter. So detrusor areflexia with normal sphincter tone is not commonly seen. It is possible in female dogs with an upper motor neuron bladder. The process is similar to detrusor areflexia with sphincter hypertonus, but with the short urethra, the external urethral sphincter tone is minimal. The most common injury to the pelvic nerve without injury to the pudendal nerve is what you would typically see this with, an example such as with a pelvic fracture. Treatment is the same as detrusor areflexia with sphincter hypertonus. So if you have detrusor areflexia with sphincter hypotonus, this is a lesion from S1 to S3, or a lesion within the autonomic ganglia. Examples of this would be an FCE within the S1 to S3 lesions, spinal fracture, or caudal disc herniation, or potentially dysautonomia. So dysautonomia is a rare condition involving the degeneration of the neurons of the autonomic nervous ganglia, leading to sympathetic and parasympathetic dysfunction. It has commonly been reported in dogs and cats in both the United Kingdom and Scandinavia, but small clusters of cases in both species have been seen in the United States. Its underlying cause is unknown, but neurotoxin exposure is strongly suspected. In addition to the classic findings of unresponsive mydriasis and prolapse nictitating membranes, the abnormalities seen with dysautonomia can range from ileus and constipation to decreased systolic function of the heart. These dogs and cats often have significant voiding dysfunction and urine retention caused by bladder atony and overflow incontinence secondary to urethral sphincter incompetence. There is no specific treatment of dysautonomia, and spontaneous remission is uncommon. The prognosis is related to the severity of clinical signs and the specific organ functions affected. Management of urinary complication is usually possible, involving bladder expression and or urethral catheterization, along with parasympathomimetic agents. It is the challenging management of the gastrointestinal sign components of the disease that often leads to euthanasia. So the next type of bladder is detrusor hyperreflexia, and this can be from partial upper motor neuron lesions or cerebellar lesions, such as cerebellar hypoplasia or idiopathic cereballitis. It can also be seen with cystitis, and this type of lesion is actually seen very common in people with upper motor neuron lesions. So when we talk in pets, and mainly in dogs and cats, when we say an upper motor neuron bladder, we're talking about a bladder that is firm, distended, but is very difficult to express. In people, when they use the term upper motor neuron bladder, they're typically referring to a bladder with detrusor hyperreflexia. This can occur in dogs, but is not commonly seen. So for treatment, we want to decrease detrusor contractility. So these are the two that have been shown. These are anticholinergic medications, and this is not something that I have ever seen before. Again, this is not commonly seen in our four-legged patients, but this would be the treatment for such a bladder. Now, if you have normal detrusor reflex with decreased sphincter tone, this is most commonly seen with what's been called urinary incompetence. The lesion may also be from a structural abnormality of the urethra. So if there's a loss of pudendal innervation or a loss of sympathetic innervation to the urethra. The latter lesions are quite uncommon, but something to consider if you have a patient that presents with signs of urinary incompetence. Treatment for this is to increase urethral resistance, so phenylpropanolamine is going to be most common, or some sort of estrogen supplementation in female dogs, potentially testosterone supplementation in male dogs, although this is not commonly seen in male dogs. Reflex dyssynergia is a loss of coordination between the detrusor muscle and the urethral sphincter. This is primarily seen in male dogs, with Labrador retrievers being most commonly reported. This can be secondary to lower urinary tract disease, if there's peritoneal trauma, prostatic disease. So those need to be ruled out before the definition of before the diagnosis of reflex dyssynergia can be made. So with reflex dyssynergia, these are patients that will posture to urinate. So the sensation for urination is completely normal. A lot of times these patients can produce a normal stream for a second or two, but then the stream will stop and either significantly decrease or completely stop altogether. And some patients can be so severely affected that no urine can come out at all. They posture, but they will seem almost like they're completely obstructed. And this is due to lack of relaxation of either the internal or external urethral sphincter. Unfortunately, the cause of this idiopathic reflex dyssynergia is not well known, so all we can do is treat it as though they were an upper motor neuron bladder. So typically, we will start with doing some sort of alpha-1 adrenergic blocker with prazosin, potentially doing phenoxybenzamine as well. We can also give diazepam as a second treatment, and then typically we don't add in bethanechol because these patients have very good tone of their bladder, but over time the bladder wall can be damaged and weaken over time. And if there's cystitis, urinary tract infections associated with this, sometimes later on in the course of the disease you do have to add in bethanechol. But most of the time, if you feel these patients' bladders when they're trying to urinate, they will be very firm. So these are patients that typically the external or internal urethral sphincter are not relaxing, so they need a medication to help with that. The last group of Micturition disorders is detrusor areflexia from overdistension. So this can be from a number of different causes, but urethral outflow obstruction is going to be most common. So in the cat, if you think of your block tomcats, that's going to be the most common cause of this. It ultimately is from a loss of excitation contraction coupling of the detrusor muscle because it's been overstretched. But within 1 to 2 weeks, this can heal. So a lot of times we'll place a urinary catheter for several days or potentially for a week or two if it is needed. And you can consider adding in bethanechol. The patient does seem to have some activation of the bladder. This can help empty the remaining part until it can fully heal, and the excitation contraction coupling can occur again. It's in a way similar to the heart and how there can be the excitation that goes from cell to cell. The bladder functions in a similar way. So that is all I have for you.